Hi everyone, my name is Cheyenne Halstead, and today I'm going to walk you through case study number 10 in our text. The case is about a 7-year-old man who comes into the ED with dizziness, dark red diarrhea, and signs of significant volume loss. I'm going to break down the likely causes of his GI bleed, assessment findings, the labs, and what interventions we should prioritize as nurses. Jumping right into question one, what most likely precipitated CW's GI bleeding? So starting off, CW already has a pretty rough medical history. He has cardiomyopathy, AFib, a previous ulcer, and he's taking multiple medications that increase bleeding risk. Two things that jump out at me immediately is one, he's taking warfarin, and his INR is 4.8, which is extremely elevated, and that alone puts him at high risk for spontaneous bleeding. Two, he also takes diflucanac, and that's an NSAID, and he's taking that about 3 times a day. And we know that NSAIDs can erode the GI mucosa and cause major GI bleeds and ulcers. So combining the NSAID with an already high anticoagulation level is basically the perfect storm. Number two, signs and symptoms of GI bleeding and volume loss. So again, I would say the dark red diarrhea tells us that it's a lower GI bleed or rapid bleeding. He has hypotension, they said 70 over something. Tachycardia, his heart rate is between 110 and 118. So it seems he's trying to overcompensate there. Dizziness and anxiety, which can be early cerebral hyperperfusion signs, cold and clammy skin, and delayed cap refill, meaning he's having poor perfusion there. Low urine output, it seems the kidneys aren't getting enough blood flow and can't perfuse correctly. And then he has mid-epigastric tenderness, consistent with the ulcer issues. So it seems he's losing blood faster than his heart can keep up, and his body is overcompensating by shunting blood to the vital organs, raising his heart rate and pulling from that vascular space, which is making everything else shut down. Number three, I would say the most serious potential complication here would be hypovolemic shock for sure, and that can lead to organ failure and cardiac arrest. And considering his history of cardiomyopathy and the fact that he has an ejection fraction of 13, he doesn't really have much reserve there, so any bleeding, moderate to high, could be very fatal for him. Number four, abnormal system findings. As far as systematically, neurologically, he's dizzy, sleepy, and anxious. Cardiovascular, hypotension, tachycardia, and weak pulses. As far as GI, active bleeding and abdominal tenderness. As far as GU, decreased urine output. For skin, it's pale, cool, delayed cap refill. Respiratory, slightly elevated respiratory rate. And psychosocial here is he's fearful and restless, probably from that poor perfusion. His body is basically screaming that he's not perfusing well. For number five, what intervention is needed to assess renal function? To evaluate his kidney function, I would definitely, the most important thing we have to do here is track his urine output hourly and trend his BUN and creatinine. He's already showing signs of renal injury because of the poor blood flow. Number six, calculate MAP and why it matters. So using the blood pressure of 89 over or 98 over 52, it's about 67, and the MAP tells us whether the organs are being adequately perfused. And for most patients, we want a MAP of at least like 65. And because he has heart failure, he actually needs a little more to perfuse well. So like 67 is barely skating by there. Seven, which labs are most concerning? Most of his labs are actually pretty alarming, but the one that bothers me most is the INR of the 4.8. because it directly correlates with the uncontrolled bleeding. And then he has his hemoglobin is 8.4, and his hematocrit is 25%, which is also concerning. But the INR tells us why he's bleeding so rapidly. Number 8, which diagnostic test is needed? With an INR and suggested or suspected GI bleed, I would suggest a repeat endoscopy and a CT angiography if the bleeding continues. But right now, stabilization, I think, for him is the most important, and that should come first. Number 9, ECG and electrolyte effect. The ECG is showing some sinus tachycardia, which fits with the volume loss. No big electrolyte induced rhythm changes yet, but his potassium is slightly high, likely due to that low kidney perfusion or his perfusion problems. 10, why are the BUN and creatinine level elevated? Again, it's likely due to prerenal AKI and caused by the hypovolemia. His kidneys, again, they're not perfusing well, and the waste products are building up. Number 11, what would we do? What do the low hemoglobin and hematocrit tell us? These numbers pretty much reflect the acute blood loss, and the rapid drop suggests that he's been bleeding pretty heavily, and it's been recent. For number 12, reason for prolonged PT INR, that's straight from the warfarin. He's super therapeutic, and so his clotting is impaired. Number 13, response to the prolonged INR. We would definitely hold the warfarin, avoid any unnecessary sticks, monitor closely for bleeding, prepare to give him FFP, which he does get later in the case. And this is exactly what you expect in someone hemorrhaging while anticoagulated. 14, safety precautions. We would definitely put him on fall precautions, bleeding precautions, no razors, soft toothbrushes, and continuously monitoring his stool and any vomit for blood, frank red blood. 15, why is his white blood cell count elevated? I would say that's likely due to stress. That's a stress response, and possibly inflammatory reaction from bleeding. 16, purpose for FFP. FFP helps replace clotting factors and corrects the elevated INR so he can actually clot. For 17, the fluid balance. His intake was 8,498 mLs, and his output was 3,660. So that's like a positive balance of 4,830 mLs, and it shows that his kidneys just aren't perfusing as well as they should be. 18, why monitor fluid status so carefully? Because he has severe heart failure, and his ejection fraction is 13%, so too much fluid can push him straight into pulmonary edema, which can be fatal for him. 19, 6 things to monitor for fluid balance. I would definitely monitor lung sounds, daily weights, strict INOs, peripheral edema, and if it's pitting, respiratory effect, and his vital signs, looking for worsening heart failure or fluid overload. And 20, comfort measures for his wife. I would definitely keep her updated and abreast of everything we're doing, giving her warm blankets, setting her up with the Barco lounger, giving her sheets, giving her any drinks or food she might need. She's been there for a long time. She's probably hungry. Letting her know like what all the equipment is for. I'm guessing he's going to need he's going to need blood. So just explaining everything to her, making sure she, knows what's going on, and, kind of reassure her that his symptoms are what to be expected for what he's going through, and letting her know if anything, else arises. 21. Which findings show he's improving? He's less drowsy, more alert, his BP is stable, he has a better urine output, which is a pretty good sign, and all the signs pretty much point to the fact that he's perfusing better. So overall, I would say that this case study is a good reminder of how quickly a GI bleed can escalate when taking a high dose anticoagulant or taking NSAIDs, and really the education that we have to do for our patients to let them know the signs and symptoms or the risk factors and signs of bleeding, and really just recognizing the signs for ourselves, and intervening as fast as we possibly can, to get it under control. But yeah, thanks for watching my presentation, and that was case study number 10. Thank you.